I think this is very powerful that we are starting on such a positive and a strong note of collaboration right away under this summit.
Right, Kanishk, and this is the most beautiful start we can get of this day, and because the vision shared in our inaugural session to the energy in this room, it's clear that we're not just here for the summit. We are here to shape the future of reproductive health in India. So with this, I would like attention of all my audience sitting here, because we know this comprises of our researchers, clinicians, embryologists, and students as well. So it's a little warm-up session with a quick question just to check how do you remember the textbook questions or little history of our IVF industry.
Okay, this is how we do it.
Yes.
You asked a question from here.
Okay.
Okay. And I'll go to the audience.
Okay.
Whoever knows the answer, raise your hand. Okay? And there's no goodie. Please. But yes, you get the chance to boast. All right?
Yes.
Okay. So the game is very simple. You have to raise your hand, and whichever hand I see going first gets it. So let's see if it is the very premium front VIPs or my students right there. Okay? Let me see who gets it first.
So, okay, let's have the question on screen. Where was India's first IVF baby, Durga, born?
I saw that hand going, no, nobody answers. So she was the first one right at the back, and you were the first one who raised your hand. So first of all, what's your name?
Hi, I'm Yashika Kushal, handling corporate communications at Nova IVF Fertility.
Brilliant. And what is the right answer?
Kolkata.
Yes.
So she says Kolkata, huh?
Yes, it is Kolkata.
Oh, wow. I think everybody has to give it a round of applause to her, please. Go on.
Correct. So the right answer is Kolkata, and the first Indian IVF baby, Durga, was born in 1978 in Kolkata, just months after the world's first IVF baby was born in the UK. A proud moment for our medical community and for India's place in global reproductive science. And with this we now turn our attention to something just as vital, the legal and ethical foundation that holds the IVF ecosystem together. Kanishka, would you like to put on light something on this?
So we are now getting into the next panel, ladies and gentlemen. And this one is titled as Laws of Life, Art, Access, and Autonomy. So we'll be exploring the evolving legal landscape under this panel discussion of the ART and the surrogacy in India. What is it that's changed? What still needs your attention? And how the regulations can uphold patients' rights while enabling fair and safe access to care. From questions around consent, I think even during this last session, there were questions about the same which were being asked, whether this is still transparent enough, where I think Dr. Amit had brought up this quite precisely around the consent, the eligibility, and the documentation to broader issues like ethics and affordability. So this session will be kind of encompassing all of this. So let's welcome in our panelists.
Yes, and now it's time to welcome our experts for the panel discussion. Dr. K.D. Nair, Chief Consultant in Fertility and IVF, Akansha IVF Center, immediate past President at IFS. Welcomes, and let's welcome our dignitaries with a round of applause. We have a lot of energy and we're ready to hear the expertise our panel speakers are going to share. Dr. M. Gauri Devi, Director, Department of Reproductive Medicine, Ridge IVF Private Limited, Director, Gauri Hospital Limited, Past President, Indian Fertility Society, Vice President, Fertility Preservation Society of India. Let's welcome our speakers with a round of applause. Mr. Divyanshu Priyam, Partner, Lex Curem.
Welcome, sir. I think you have to give him a round of applause. It's right in the morning. Come on, everyone.
And this panel will be moderated by our moderator, Mr. Manu Varghese, Partner, Vertices Partners.
Thank you. So the onus is all yours, Manu, sir. Let's have a wonderful session. All yours.
Hi. So, from the first question that was asked, when was the first baby born? First IVF baby in 1978. Since then, India has been a prominent hub for assisted reproductive technologies. Yet, it took us 27 years for ICMR to bring out guidelines for ART clinics. From 1978, it took us 44 years for us to have legislations in place. So we had the new legislations, ART regulations, and the Surrogacy Act in 22. Now, undoubtedly, the ART and Surrogacy Acts are landmark legislations in the right direction and sets the stage for shaping the future of ART. However, given the rapid evolving technology, changing societal norms, and moral considerations, it is imperative to evaluate the impact, strengths, and weakness of these regulations. And on this panel today, we will explore how ART and surrogacy laws are shaping access, equity, and autonomy in modern fertility care. With that, I will commence this panel discussion. First question to Dr. Nair. Sir, in your view, which elements of the current ART and Surrogacy Acts are misaligned with clinical realities, and how might some compliance mandates be contributing to unnecessary administrative burdens without actually improving patient outcomes?
See, the initial misalignment is about the age limits which the government has put, that as per the guidelines, as per the law, only women between the age of 23 to 50-year-old and men up to 55-year-old are allowed to have the IVF procedure. But in India, when we look back, many of our cities and villages, the age of marriage is very early. They are marrying at 17, 16, 17, 18. And by the time they are 20, they have already produced 1 or 2 children. But in case they are not able to produce children, this type of couple, they cannot go and undertake IVF services because they are still not in that age group. So that misalignment of age, I think it can be modified by the government. They can bring it down. And the second misalignment is about the marital status, that the IVF procedure is only available to married couples or a single woman who is divorcee or widow. There have been cases in the past when single men have also wanted to have a children through surrogacy, which is no more there. Probably we can also remodify this law that even a single man or same-sex man, same-sex, they can also go for procedure as per the law. And when they modify the law, they should be able to undergo this thing. I think these are the two misalignment which can be very easily corrected by the government. It doesn't need much thing. Then the other is about gamete donation. They say that you can donate only once. And I think we have to modify it. That the thing is, right now you can donate only once. One person can donate only to one couple. And since we know the success rate of IVF procedure is nearly 40%, you may not conceive in the first cycle, you may need a second cycle, third cycle. So we can give it, limit it to the number of live births which is being produced by a single donor. I was reading yesterday that the owner of Telegram services, he has 5 children of his own, biological children, and he has more than 100 children which is born because he was a sperm donor. And he has fathered another 100 children. And he said, all my fortune which I'm going to leave behind will be equally distributed. So what I'm trying to say that similarly in India, the gamete donor, the scope of gamete donor can change to the reality what we are facing here. That we find it very difficult to get a oocyte donor or sperm donor. We have to run from bank, ART bank, one bank, second bank, and you have issues with them. So I think the law needed little modification in this donor thing also. And
So if I can ask from a administrative burden point of view, in terms of paperwork, how does that affect you and how does it affect patient
yeah,
outcome?
because now the paperwork has increased tremendously. All the IVF specialists sitting here in Delhi, we are sending the whole report, all the procedure which we have done, we are sending the whole report in the beginning of the month. By 5th of the month, we send the report to ART office. Then again in the middle of the month, 15th of the month, again we send them the report of how many are positive, how many are negative. And they want it in a very particular way. I need to have one dedicated typist only for this purpose. I can afford to have one typist along with other supporting staff, but maybe if you are a smaller clinic, you may not be able to have this type of thing. And if you have any problem with your data, anywhere you are in a big this thing fix, you have to clarify it, that it is a typographical mistake, it is this. So my typist has to type it and then one of my colleagues has to check it before we send it to the PND, the ART office. So that has definitely increased. Now all the data which is going to ART, I don't know whether those people sitting there, they are analyzing it, because the earlier panel wanted, we have no data in India, how many cycles we are doing. This is very basic data. I think since we are sending the data to ART people, that is one nodal agency, they can publish the data. Okay, this one is IVF center has been done in Delhi in the month of June, because all the data is there with them. It is very simple data, but they have not come out with this. They have not come out. We are only thinking, talking, so many cycles have been done till now, what is the future expectation. But the data is already there with them. They should come out. It is not a big analysis. The number of IVF cycles done, they can give. That is, and that can help us in planning how to go about it in future.
Okay, thank you, sir. Ma'am, Dr. Gauri, to you. Sure.
One more point is that I don't know why the same-sex couple cannot have a child. Live-in partners cannot have a child. In US and all European countries, they allow it. But here, they cannot have an IVF. That's again another...
I'm one of that. Yes, I'm a live-in partner, so I don't know how many of you have pets here. So I have a dog. Now, having a dog
See,
is
that,
akin to having a small child, because everything for my dog, I need to take care of it. Unfortunately, I cannot have a child though. I'm not equating the two, but the fact is, nobody asks me any questions in having a dog. I don't sign any papers, an adoption paper at best, if I'm taking the dog from an NGO. That's about it. But when it comes to a child, there's absolutely no option.
Exactly.
My partner can, however, go on her own. That's the loophole in
And
the law.
one more thing is that they have written single woman can have a child, but one gray area is they have written in the next either a divorcee or a widow. Now, why can't a person who is not a divorcee or not a widow, why can't she have? So these are things which we have to work it out. And
Certainly.
I just don't understand why can't live-in partners have a child? What is the problem? Whatever problem is there, they will sort it out. How does it matter to?
But I think, Dr. Gauri, I think recently they had come out that live-in people, the children born to live-in couple is also entitled to have the same right.
But they are not allowing them to have.
No, that IVF is not allowed, but the children born to the live-in couple is having the same right.
Of
Rights
course,
they probably
Yeah.
can produce.
certainly.
I would like to add something. So, single woman is allowed to have a child through IVF, but there's a point 21G, which allows single women to have IVF done on themselves.
Yes.
As you were saying that there's a loophole. So that loophole is that if you're living in, if you're in a live-in relationship, you can go get a IVF done with your own partner's.
No, what is 21B? You have the law. No, you can't have, it is next, this thing is either married or divorced.
That is for surrogacy.
No.
I think, Dr. Gauri, probably they have not changed it. They have made it any single woman can go for IVF. Previously, it has to be widow or
here, ma'am.
divorcee. Now,
Above the age of
any
20,
single
I've
woman
highlighted it.
can go for IVF.
So you have an option.
He has an option. His wife, she can go for
That's what I
IVF,
said, ma'am. That's a loophole.
and he can be a donor for her.
I will be the helper.
Yeah,
Yes. You can be the donor.
you can be a donor.
Yes.
The other big issue concerning IVF is surrogacy. You see, we have been, when there was no law, there was unregulated surrogacy. Now with the law, they have made very strict condition. Foreigners are not allowed to have surrogacy done in India. That is okay, that is a good thing. But about Indian couple who are looking for surrogacy, initially they put it only altruistic, that you have to bring a woman from your family, from your relation, who is willing to undergo surrogacy for you. Then they change it to a woman who is known to you. Even your friend or anybody can be a surrogate. But in reality, this is the law. In reality, we don't find any woman who is willing to undergo surrogacy on her own. We always have a woman who are willing to undergo surrogacy for financial benefit. And there are agencies, I don't know about Bombay, I think they must be the same. In Delhi, we have agencies who need a surrogacy, we contact them, they will send a surrogate. But now, of course, the surrogacy procedure is so difficult. First, you have to go to AIT board, get a permission that you are allowed to have surrogacy. The board will decide whether you are fit or not fit to have surrogacy. Then the other legal papers start. So it is a very time-consuming affair. And the bottom line is, before the law, in Delhi, we can get a surrogate for, say, for 10 lakh. Now, after the law, you can get surrogate for 20 lakhs. The price has jumped almost 100%. And this money goes to agency. It doesn't go to the surrogate mother. That is what they wanted, that the woman who becomes surrogate should be looked after, she should have some benefit. That is not happening. The money is going to the agency, who are pocketing it. So this surrogacy, the altruistic part has to be redefined. Probably any woman who is known, they should fix the amount the woman will receive. That is very important. The government can fix amount. This woman must receive that much amount. Most of the money is being pocketed by the agents. That is the problem.
Officially, agents are not allowed.
Officially, they are not allowed.
That's not
the law.
allowed. What to do?
But if somebody needs surrogacy, he or she has no other option. He or she has to find some agency to. You don't have a walk-in woman, okay, I'm agreeing to be surrogate for this couple. No, you don't have.
Sir, Supreme Court recently said the same thing in Arun Muthuvel case, that surrogate mother is somehow obviously going to be compensated. So draw a framework, or we will we'll give an order to draw a framework which where the state would draw a pool of ladies and they would be adequately compensated. So this was Supreme Court's view, but the government's view is different due to the ethical dilemmas that are involved. So they do not want to state that we are commercializing the body of a woman to have a child. They are, Supreme Court says a different thing and the government has a different point of view, according to me.
Right, but the woman has a choice, no? I don't want to be a surrogate, money or no money. So the woman has a choice. If she wants to do it willingly, why not? She is getting compensated for it. Only thing is antenatal care should be good. She should not be, the treatment care given should be good. Give it to her. The choice should be the woman's. Take it or leave it.
Correct, ma'am.
So, ma'am, the next question to you. Do existing ART regulations adequately address the unique considerations involved in fertility preservation, such as for single individuals or patients with medical risks? Or are clinicians still navigating regulatory gray areas?
Clinicians?
Are clinicians still navigating regulatory gray areas in such cases?
See, generally things are very clear, like any woman who want to preserve her fertility, whether any disease or not, suppose younger age she wants to preserve, yes, she can. No legal problem is there. Second thing is that if any disease like cancer or some of the autoimmune diseases where their fertility is affected when chemotherapy or radiotherapy is given, these patients have no problem, we can keep it. Problem arises when something like posthumous this thing, a person dies and without giving a signature for fertility preservation, and then the parents are they have only one child, the parents are all nervous now what to do, now you take out the sperm or you take out the, that is a gray area, that is not permitted, especially if it's an unmarried man. Then they go to the Supreme Court for or the High Court for this thing, and even now it's on the in the this thing that
Recently,
very recently,
Ganga Ram was
Yeah.
the hospital, and a patient, Gurmeet Singh or Gurvinder Singh, I may have to correct myself later, but the name was something like this. Their parents went to the High Court and got a permission from Pratibha M. Devi to get a posthumous reproduction with the help of their son's sperm via surrogacy.
Yeah.
So obviously we are evolving somewhere.
But they had to go to the court. The government was not permitting it because according to rule, a single man cannot have a surrogate child. So he doesn't stand a chance. He,
in this particular case has not given a complete verdict in India that if such cases come in future, who is the legal heir to the sample?
they
That's
gave
the
only
question.
permission for this patient.
This patient, but
Yes.
a
Yes,
verdict.
only for this
So-
patient.
Yeah.
No, but a verdict has to come because the centers are in dilemma. This sample had to be kept for 3 years before the High Court told us you release it.
Yeah.
For us, the sample is released, but we don't know what has happened to the sample further. See, this is the problem.
Ma'am, in this case, particular case, the parents gave an affidavit that we will be taking care of the child, and since my two daughters are of the appropriate age, there was a argument by the court, by the council for the state, that you do not even come in the adoption area. So there's the adoption criteria, median
Yeah,
age.
age.
So you do not come into that age as well. So what they told us that we are giving our affidavit that we will take care of the child, as well as in our absence, our daughters would be the ones who will be taking care of the child. So this is a very selective judgment that has been given, and only for this person.
Only for this case.
Only for this
Yeah,
person. This
only.
is very exclusive
Yeah.
to them. Very exclusive to
So
them.
this will be a landmark case maybe for many more cases
Yes.
in future.
Yes.
Yeah.
That is one aspect that you have this type of case, whereas the other question is how long to preserve the gametes. As per the current law, is 10 years. But in certain cases, with a patient who are having cancer and other thing, you need to preserve it for a longer time. And for that, if you want to preserve it for a longer time, you have to again apply to the AIT board to extend this preservation, you see. So there is a lot of paperwork involved. You freeze a sample of somebody, and if 10 years has gone, he should again apply to AIT board to continue it further freezing.
And one more thing is there, as a fertility preservation society vice president, you know what, all over the world, however many samples are preserved, especially the oocyte preservation. Believe me, for return for those frozen gametes or embryos is only 20%. Now 80% are languishing in the cryo tanks. That becomes a problem. Do we destroy it? Ethical consideration. Do we destroy it? Sometimes they don't even, approaches at all as to what is to be done with them. Some of them spontaneously conceive, some have died, some have not come back for this thing because the partner has already married, especially in cancer and all, partner is already married elsewhere. So many ethical considerations are there when we do these precincts.
Moving from there, Divyanshu, to you. What are the most pressing legal and procedural challenges in implementing the Surrogacy and ART Acts, particularly in areas like surrogate consent, donor identities, and eligibility criteria? And how are these ambiguities affecting timely compliance within fertility practices?
So, in the beginning, there was no knowledge even to the authorities. So, firstly, we had to educate them even on the ART as well as the surrogacy laws. It took me personally almost a year going through the nation, across the nation, and then educating them, trying to learn with them, because an act, you do not get everything at once.
True.
You have to go, since you're a lawyer,
Yes.
we have to go through it again and again, then you draw something out of it. So there were many problems in the beginning, but at the end of the day, the heart of the acts is at the right place. The doctors were already doing the compliance for PCP and AT Act. They have, and this, I would call it an extension to the PCP and AT Act, because the departments which are handling this is PCP and AT only. This work has been given to PCP and AT people only. So, yes, there is delay. There is a because some states have adopted some procedure, other states have adopted different procedure. Some states are, when it comes to ART, some states have made district appropriate authorities to give the licenses. Others have, like Delhi has a state appropriate authority. In Maharashtra as well, the state appropriate authority gives the license for the ART. Whereas in Haryana, it is district appropriate authority which is giving the license. So there is still conundrum around this thing, but I would say the law is in its nascent stage. It is evolving with the dignitaries like Sir and other. Dr. Talwar is there in front of me. He was the one who was working with the government to make sure that everything is implemented. He was the one who was educating the Haryana people how to go about it. So this cooperation, and when these two sides of the society will meet, we'll obviously find something which is good.
So just to add there, we did have the ICMR guidelines of 2005. Now, how did that impact this legislation also?
So
Because a lot of learnings could have come from there as well.
the ICMR guidelines did not have the teeth to bite. These have.
Okay.
These have penal consequences.
Penal
as well.
consequences, yes.
The Act has penal consequences for non-maintenance as well. So the intent is to make sure that everything falls in the right place, compliance is done properly, and according to the world standards. That is the intent.
Then, since you said penal consequences,
Yes.
in your view, what is your view of the penal consequences? Do you think it's too harsh, or do you think it's in the right place? The heart is there, but what is the actual intended consequence from this penal consequences?
So the intended consequence is to to regulate the practices of the clinic in a manner that there is no mix-up, there is nothing against the society and the people. Earlier, there was one man you take and you give the semen to hundreds of people as the telegram person.
Yes.
So after some time, after 20 years, let's say 20 years, those 100 people somehow they entangle, then what would the result of that? That would be incest in a manner.
Yes.
So ART, when we say that only one person can give
To
their
one consenting couple.
one time.
Yes.
So obviously they would have thought something about it. There is a proper select committee report behind it. Their intention has been discussed properly. So I think it, again I would say that the act is in right place. It requires a lot of I would say comments and feedbacks from the doctors to the board, to everyone, to the authorities, that what needs to be changed, how we can improve it, and then everything I think would be fine.
I think taking this question to the doctors on the reality of things. In yours, since we just spoke this question of one donor for a couple, now how does that impact from from an actual scenario? Do you have enough donors, both in terms of male sperms and female eggs, for couples, or is that something that we need to figure out?
At the moment, it's a dicey in the sense, it requires people to be talked about giving. In India, or at least in Delhi scenario, it's very difficult that you find, highly educated lawyers or doctors or scientists or such people to donate semen for this purpose. No, they shy away from it. So they are collecting from people like university students or college students who are in need of money, who might want to give. That is the thing. Now, when you say one donor, what is in the government's mind as far as this is concerned is a very, very, very rare chance of an incest. That is what is in the mind, I suppose, when they say don't take too many donations. Now, as he rightly said, who was that fellow, 100 children? Yeah. Now, yeah, now here it was, now at least because of the RT bank, that much of anonymity is not there. Previously it was anonymous. Now there are 100 children who are growing, knowing this is my father, and suddenly somebody is giving money to them, telling I am the father. See the turmoil in that person's mind, what will be happening. So it's a very, very grey thing. I personally feel once maybe you can make it, because in a semen donation, it doesn't make that much. Like in a woman who is delivering a child, yes, there is a risk. In a semen donation, there is no risk. So more than once or twice, it doesn't really matter. But what is the upper limit? I'm not the authority to say.
I think we can fix it to the live birth from a particular donor, how many children have been born. Then government can fix certain criteria, 1 child, 2 child, like this, because the success rate of IVF procedure is also not 100%. It's 40%, 50%. So you may need to.
A lot of data.
So from a practical standpoint, how much of this data is actually in place? For instance, can a donor go to one bank, donate, go to the next bank, donate?
You see,
Who
that
keeps
is the
track of
problem,
that
because there
information?
is still no data with the government. There is no Aadhaar card. The identification of donor is also not put on the website. So donor comes to, supposing my center from agency, they say send me the paper, they give the old data, his Aadhaar card, everything is there. And after 2 months, she goes to another center for donation, and this doctor will also accept it. Because the Aadhaar card, everything is still, it cannot be cross-checked whether this Aadhaar card has been used for donation or not. And people are very manipulative. They are making a fake Aadhaar card also. You can get a new Aadhaar
Same person
card.
has 3 Aadhaar cards.
Two Aadhaar cards, 3 Aadhaar cards. So there is no problem. You can have 3 Aadhaar cards in your pocket and go from different centers.
So government really lags on this front. There was to be a national registry to make sure that all the data, all the donor data, all the IVF data is to be collected there. So government has not done anything to make sure that it happens.
This it is all under process. Even the AIT board, appropriate authority is also under process. So once the appropriate authority is established, only then they can think of having the national registry. So each state is different, at a different level.
So my next question is to you. What role should professional associations play in actively shaping ART policy? And how can advocacy frameworks be strengthened to ensure medical expertise drives the future of reproductive regulation?
You see, basically this ART law has been drafted by a subcommittee of the parliament, and they have invited few specialists who were working in this field. They are given their advice. How much advice has been accepted, we don't know, but they came up with the law. Now, all of us understand that this law needs little remodification at certain points. Probably it may also come through in course of time. As a professional association like IFS or ISAR or ACE who are sitting here, we have a role in the sense we can set the guide, discuss among ourselves, set the guidelines and give it to government to act upon these guidelines. When they need modification, we can advise them that these are the points which need modification in the law, and that is the consensus of, say, IFS, ISAR, all the association. They can go about it, and they can send this recommendation to the government, which should be accepted. Because once it is coming from a society, that has a weightage behind it. When all the society join together, that has a weightage. Like Dr. Patkiva mentioned that starting on Ayushman Bharat, similarly, I think they can send this modification to be done in the ART law to the government. It can be there. And the societies, our society, they have this responsibility of training the future specialists, the future people who are going to practice ART, to have to oversee their training part also. This is a field which has a lot of scope. The government is doing its own part for the training purposes, but the societies also have a role on doing the various meetings, CMEs, and giving the message to the younger generation, what are the updates happening in this field. So this is very important, which may not be available on the books. In the books, it comes little later on, but in the current form, the CMEs and this thing, seminars, it is very easily available. And that is the job, that is the responsibility of the societies.
So I also think the judiciary is playing a large role in trying to, fix a lot of these loopholes. So I'll give you an instance. About 8 years ago, a friend of mine, she got a baby through surrogacy. Now, when she went to her office asking for maternity leave, they said, there's no maternity leave for you because you're not the mother. You're not the mother, this baby is not born through you. It's a different thing that, like they say, when you really want something, the universe conspires for you. 48 hours after she asked for that leave, office said no. Modi ji implemented lockdown. So she got what she wanted in a very indirect way. The fact is that now, about 6 weeks ago, there is a case of Lata Goyal, where the Chhattisgarh High Court has finally said that motherhood is a fundamental right under Article 21. So as a surrogate, as a mother who has got a baby through surrogacy, you're entitled to maternity leave the entire period, 180 days. But that is where I think a lot of things, in the cases which he also mentioned, we go back to the court, either High Court or Supreme Court, which are stepping in a lot to resolve a lot of these issues. And that's just like any other legislation in our country. It's not necessarily just for this. But that's a lot of, there is a lot of scope, and yes, there's a lot of intervention also happening, at least on the legal and judicial side.
Even age also, I think it was the Kerala High Court who gave this thing up to 50 years. They were initially saying 45 years.
In Kerala as well, in Delhi High Court, in one judgment, has allowed above age as well.
Yeah.
For to go through IVF as well as surrogacy, both.
Both. And also, there's this thing from Madras High Court, Chennai High Court.
People who are approaching the court has a very lenient view in some cases.
Yeah.
Because what I see is that High Court has a very lenient view when you explain them the case, they understand and they allow it.
Yeah.
So, but this should not have been there in the first place. the act should have been made in a manner that it facilitates everyone who wants to have a child, who is physically fit, who is medically fit to have a child.
Actually, it is evolving, I think. What has come initially as guidelines, that has evolved. Now amendments are coming every 6 months or something. Some amendment is being added to it. So once the whole thing settles down, maybe. And science is also progressing. So every time there is a lot of new things coming up. And now, as the previous panel, they were talking, epigenetics is one thing we should take into consideration. What's happening to the children that are born? Are they having a healthy life? Are they all well? This also need to be looked into. And patients should have all the right to information. They should be given all the right to information, a chance of a second opinion if they want to take it, and if they want to complain. Even in this law also they have said, you keep a complaint box that they can put a complaint. If it is there, everything should be told to them. That this is how it is. Consent should be taken properly. All these are very important as a legal.
I would think, as as stakeholders in this, all of us have a duty also to come together and assist the government, because expecting them to keep changing keep with the times, it's more on us to, in fact, educate them.
It is 0.0001% of the total healthcare. So it should be us, it should be the doctors and dignitaries like you to go forward and make sure that what challenge you are facing should be gone away with.
Addressed to them,
Yes.
Ma'am, question to you. What specific regulatory reform, such as expanding patient eligibility, revisiting licensing protocols, or promoting integrated public-private ART initiatives, which of these can enhance access while maintaining ethical and clinical safeguards?
Access from clinic to the patient?
Yes.
All of it, I would say. As Dr. Pankaj was telling, see, there is cluster of all these ART units in the premium cities and the first tier cities. What's happening in the second tier, third tier cities? In a village, you go to one of the remote villages, Uttarakhand, to get a semen analysis done, they have to travel 50 miles. And many of these cities, to get the hormone profile done, they collect the sample, then somebody in a scooter drives to Delhi, give it to the lab here, the report comes after 2 days. So we have to still outreach, whether the business, the laboratories, the clinicians, and those clinicians in those cities should be the societies, what we can do is to make these doctors aware of what is availability. It is up to the laboratory and the other people to reach that area so that they get the reports. So it works both ways, both the clinician as well as the patient. And patient should be also made aware of. And how do we as society we give patient empowerment program. This was one of our president's star program, wherein what we were doing is, go up to the Anganwadi level, and we have made charts, and we were teaching them, ASHA workers, who can tell the patient that these are all the available. They are not aware of it. If there is infertility, 7 years, 8 years, they don't know where to go. So this is what is needed from all of us.
So, ma'am, on that related question, how do you handle the ethical dilemma here? I'll give you an example. A friend of mine, she is married into a joint family. She really doesn't want to have kids this early in her life. But being in a joint family, there's a lot of family pressure that, it's been 1 year after marriage, where is my grandchild, etc., etc. Now, she and her husband have gone for IVF. She has signed her consent, but that's under a lot of pressure. Now, where is the ethical part of it? Is that really consent? And how do you handle at a practical level?
No, see, this is a social cause. This is not a ethical cause. It's a social cause. That woman had no spine to put up with it. No, I don't want this baby right now. Now, she has signed it. In that, what ethics is there?
I agree. See, this is complying with all the legal requirements.
Exactly.
But this is somebody who is very educated, etc. Now take that to a tier 3, tier 4.
Take it to?
A tier 3, tier 4 level. At a village level,
Ah.
where the person may not be that educated, but wanting to do a similar IVF process. The consent there, is it just paper? Or are we doing enough?
You see, when you take consent, you are supposed to discuss it with the patient and explain to the patient in her own language, preferably. That if you are speaking the same language, the patient should understand what she is signing and what is the implication of the procedure. You have to explain to the patient everything. This is the procedure, this is how it is going to be done, and what is going to be the success rate, what is going to be the side effect, if at all. You are supposed to explain it. It's not only just signing a paper and going for a procedure, no. As a doctor, you should explain to the patient the nitty-gritty of the procedure. And patient should be able to understand what you're talking. I am talking to a patient in English, patient doesn't know English, this is of no use. So you have to have a patient, you have to have people who can speak to the patient in the same language so that she understands. If even if not she speak in the same language, she should be able to understand what we are speaking, what she is signing for. It is very clear. You cannot have a blind consent, oh, patient come and sign, finish. No. You have to explain to the patient what you are doing, what is the planning, what is the procedure, that is all. You see, if it is also now mandatory here also, the every IVF center should have a counselor. When I went to England, I saw the patient will first walk into the room, that first she will go to the counselor. Once she spent time with the counselor, only then she will go and see clinician later on, maybe after 1 week or 2 weeks. She has to go to counselor first so that she is convinced. She is given all the information about the procedure. Only then she go ahead. And as per the new law also, here also we are supposed to have a counselor in every IVF center who are supposed to explain to the patient. And they're very clear, not a medical terminology, but I am talking about as a clinician. They have to explain in a very simple language. That is the job of the counselor.
The question you asked, as a non-clinician, what do you think we should do?
That's a question that I also have, because you can comply with the legal requirements. That is, at least to ensure that you are not going to be held liable, that you have not taken consent. But the dilemma is that consent real consent?
That is why I'm saying you have to counsel the patient.
I agree.
They have come to us.
There's no I'm not saying there's a solution to that problem.
Then
But the question again is, because the way our country is, at some level there is also, we are patriarchal no matter what you say. There is also a lot of pressure on the woman to, bear an offspring. Now, does that pressure actually...
Time is up.
Time is up by this.
Thank you so much.
Thank you so much. Thank you.
Thank you so much, sir, and thank you so much for wonderfully moderating this session. We got so much of insights from this discussion, a lot of, inputs from the audience side as well, and I was literally enjoying this. I believe our audience was also enjoying this, and that's why this buzzer sounded us a little abrupt, because we didn't wanted this to end, right? Am I right? Yes. Thank you. So that was a strong and necessary discussion that brought out the clarity to complex space and highlighted how critical and legal framework is building the trust, access, and equity in that practices. And now, for the expertise our speakers have shared, we would like to felicitate with them with a token of, gratitude. So I would request Mr. Manu Varghese to please kindly come on stage and felicitate our speakers. Dr. K.D. Nair. Thank you so much, sir. Dr. M. Gauri Devi. Thank you so much, ma'am. Mr. Divyanshu Priyam. request Dr. Professor Colonel Pankaj Talwar to please come on stage and felicitate our moderator for this amazing discussion. Let's have a group photograph.